commitment to mastering this critical domain of medical science. So I would like to request Dr. Vinay Kumar Vijayendra sir to start the temporal section demo. Thank you.
Warm welcome to all delegates, especially guest faculty. They're coming from very distance, far away from Bangladesh, and also Nandial, and also now local faculty. I'm very fortunate and grateful to all of them, and also delegates, participants. Without participants, it is not successful. And especially now Vijayendra will start, and definitely thanks. They are accepting my invitation. So now we'll start the temporal bone dissections course, and next day live surgery. Definitely this 2 days is a good learning process will be there, and we will be happy. Thanks. Now by demonstration temporal bone dissection by Vijayendra will start.
And not only that,
I request all the delegates to please make a queue for the lottery for the allotment of the seats. All delegate dissector, please come forward. All the dissector. It's just a fair election process. You have to just pick a chit, and table number will be allotted. Just please come forward, pick up chit. Just your name and we'll announce it. 9. 9. Make it 9. Your name? Shruti, table 9. Name?
Shilpa.
Table 1.
Hiba.
Table 2.
Table 2.
you keep it with you, huh?
Tell your name and table.
3. Manuja.
Manuja, table 3.
6 na 9?
6.
6. Dr. Indranil.
Dr. Indranil, table 6.
I'm sorry.
Table 4.
Table 7. You just 18. 18. You will be the assisting. 18. 18 মানে 9 নম্বরে থাকে 11 18 পয়সা 9 নম্বরে যাবে
18 মানে
সেকেন্ড লটে যাবে কিন্তু 9 নম্বরের সাথে
9 কি আছে 9
9 and 18 হ্যাঁ
9 নম্বর টেবিল কোনটা
9
table,
means
you'll be assisting on the first session and you'll be assisting
Pooja.
11 পূজা সুবিধা 11 নম্বর মানে
কার সাথে 11 12
হ্যাঁ 11 12
11 নম্বরটা কোথায়
9 তো 9 হবে
তো 11 দিয়েছে কেন তাহলে
9 into 18 হবে
হ্যাঁ
তাহলে 11 থাকবে তো
11 মানে 5 দুনি 10
9 ধরুন 9
6 দুনি 12
9টা ধরতে 9টা টেবিল 1 2 একই সাথে
ঠিক আছে
3 4
11 তো ও যাবে কোথায় 10
উনি 10 11 জুটি বাঁধবে 1 2 জুটি বাঁধবে 3 4 জুটি বাঁধবে 5 6 জুটি 7 8 জুটি 9 10 11
তো 9 10
উনি কত
তো 11 মানে
11 12 11 12
6 নম্বর টেবিলে যাবে 6 নম্বর টেবিলে যাবে
6 ম্যাডাম ওটা
তুমি একবার বুঝিয়ে দাও তাহলে হয়ে যাবে।
না না ঢুকিয়ে দিলে আপনি আর ওই স্যার আমি আপনার যাচ্ছি ম্যাডাম আপনার কাছে তোমার যান
এটা
Adil.
14 7
7
number 7, who is number 7?
ম্যাডাম 7 স্যার আপনার ये मैडम
10. Your name please?
Dr. Rani.
Rani, 5 নম্বর 5 9 10 একসাথে থাকে।
मैडम दिलीप दिया था मैडम
5 নম্বর
12 6 সাথে
6 মানে 11 12 11 নম্বর ছিল। who is number 11? number 11 মানে 6 নম্বর টেবিলে, ঠিক আছে?
6 তো দিয়েছে পার্টনার ও তো হয়ে গেছে তো 6 তো আবার দিচ্ছে না
6 আর 12 একসাথে থাকবে না, না 11 12 একসাথে থাকবে।
আপনি জানেন
আরে এটা আমি করি।
আপনি 1 to 9 দিন 9 1 এর সাথে 9 আবার 10 এইভাবে দিতে হবে
কিন্তু এখন ওর সাথে কেউ আছে না তো 6 কে কে আছে? 6 কত কত নম্বর আছে বলো আমাকে। হ্যাঁ 6 আছে তো
6 এর সাথে কত নাম্বার আছে 6 আর 12 গেছে
শুনুন শুনুন এক কাজ করুন মেক ইট সিম্পল 1 2 1 2 এইভাবে করে দাও
মাইক বেস্ট হয়ে যায় 1 2 3 4 5 6 7 8 সেটা
ঠিক আছে তাহলে ওরকম ঠিক আছে তাহলে করো। এখন যা ম্যাচ হয়ে গেছে
Hello.
এখন
Hello.
ওখানে কটা ছেলে আছে না কি নাম্বারটা বলো আমাকে। টেবিল নম্বর 6 তো 11 12 আছে
6 তো থাকবে 6 নাম্বার
6 থাকবে 11 কে তাহলে কোথায় দিতে হবে?
1 2 করে করুন না ইজি হবে
11 হয়ে যাবে তোমার। আমি তো ওইরকম ভেবেছিলাম না 5 6 দিকটা হোগা না। আচ্ছা ঠিক আছে কোনো অসুবিধা নেই 4 আচ্ছা ঠিক আছে একটা কাজ করি আর একটা কাজ কর নাম্বারটা থাক টেবিলটা আমি আবার ডিস্ট্রিবিউট করছি সবাই নাম্বার নিক আর লাখ থাক আমি উইল রিঅ্যাডজাস্ট ঠিক আছে 7 please keep your chits with you we will just rearrange the table there will little confusion just আর কেউ আছে anyone left to pick up the chit okay 1 2 participants number 1 and 2 please come here 1 and 2 who is number 1 number 2 you both be together
3 4
okay
हां এটাই ঠিক
3 and 4
आप ठीक ना है
हाँ 3 है ना number 4 प्लीज हाँ 4 5 6 5 3 है था हाँ 5 6
ये वाला आपका 7 8
हाँ 5 6 नंबर को था 6
नंबर 6
number 6 please come 6 7 8 7 and 8 please come here 4 नंबर है बचा हाँ 7 8 7 8 এখানে হ্যাঁ নাম্বার 8 বলে এখানে কি তোলেনি আচ্ছা প্লিজ পিক বলছি 7 8 8 ঠিক আছে 8 7 8 9 10 9 10 একটা 9 10 9 9 हाँ भेज दो 11 12 12 11 12 हो गया तो 13 14 13 14 15 16 15 16 16 আসেনি 15 17 18 17 के एखाने 18 এখানে বাকি
এখানে পাবে না স্যার হয়ে গেল স্যার হয়ে যায়
হ্যাঁ 17 18
এখানে পৌলো
হ্যাঁ
স্যার হয়ে গেল
এখানে একটা বাকি আছে খোলো খোলো একটা দেখো কত আছে 16 আছে নাকি 16ই হবে তাহলে হ্যাঁ ঠিক আছে হয়ে গেছে আসেনি 16 নম্বরে দিও ইওর পার্টনার ইজ কামিং ডক্টর পলোস ইজ देयर Okay, all the dissector, please take your seats and pay attention towards the screen.
এটা আপনাকে রাখলাম আমরা পৌলো
We are starting the demonstration of temporal bone. And other delegates, I am requesting to just... Other delegates. All the other delegates and the observer, please move to the first floor for the live demo and discussion.
Good morning, everyone. At the outset, I would like to thank the organizers. Thank you, Dr. Tushar Kanti Ghosh, sir, for this wonderful opportunity. I think it's a great opportunity, especially for the juniors, to learn the...
সবাইগুলো সব ছেলেগুলো সাইডে হয়ে যাও মানে মাঝখানে কেউ দাঁড়িয়ে না
So it's a great opportunity for the youngsters to learn the intricate anatomy of the temporal bone. So temporal bone anatomy is extremely
সৌমেন্দু মাইকের সাউন্ডটা বাড়াও
very complex and intricate, and you have to do multiple temporal bones in order to master the anatomy of the temporal bone. So this is a great opportunity for the youngsters provided by Dr. Ghosh to learn the anatomy of the temporal bone, and the more temporal bone dissections you do, the more confident you will be when you do a live surgery. So without further ado, let me start off with the dissection. So the first thing you need to do when you get a temporal bone,
please make silence please.
You have to fix the bone in anatomical position or the surgical position. So imagine that you are in the operating theater, you are sitting in front of the patient who is lying down. So look for the mastoid tip and look for the root of the zygoma. In this bone you can see this is the root of the zygoma here. So this will be the foot end of the patient, and I think the image is slightly rotated. I'll just turn it. Reverse. A little more. Yeah, should be fine. So this is the root of the zygoma. This is the mastoid tip. So this will be the head end of the patient. This will be the foot end. So if the patient is lying down like this is a left temporal bone. So the first thing you need to do is identify which side this is. This is the left temporal bone. Another way you can use to identify the side of the bone is look through the tympanic membrane. You can see the lateral process of the malleus here. So this is superior, this is inferior, this is anterior, and this is posterior. So again, this is a left-sided temporal bone. So today I'll be demonstrating the transmastoid exercises. First thing I'll be showing is the cortical mastoidectomy. Then I'll be demonstrating epitympanotomy, facial nerve decompression through the facial recess approach. And then if time permits, I'll be showing the anatomy of the semicircular canals, endolymphatic sac, the vestibule, and finally the internal auditory meatus. So let me begin now. So the first thing you need to do is a cortical mastoidectomy, and this is of course the bread and butter of every ENT surgeon, cortical mastoidectomy. So one has to be very confident while doing this procedure. So to begin doing a mastoidectomy, you first drill along the McEwen's triangle or the triangle of attack. So you can see this very prominent line here. This is the linea temporalis. So your first cut should be along the linea temporalis like this. And then the second cut should be parallel to the posterobone unilateral wall. You can see the posterobone unilateral wall here. And the second cut you can make parallel to the posterobone unilateral wall. And then you make a third cut joining the first two cuts. So this is a tangential line joining the first two cuts. So this triangle which you're seeing here is called the McEwen's triangle or the triangle of attack, and it's always important to initially go along this area in order to open up the mastoid antrum. And another important landmark you have to look for is the spine of Henle. So it may not be prominent in all the cases, but the spine of Henle will be prominence here near the posterobony meatal wall. And whenever you see the spine of Henle, always try to stay superior to the spine of Henle. So if you stay superior to the spine of Henle, there are very less chances of you damaging the facial nerve or the lateral semicircular canal. Whereas if you go inferior to the spine of Henle, you'll keep looking for the mastoid antrum and you may end up accidentally reaching the facial nerve and the lateral semicircular canal. So you can see this is a well pneumatized bone, which is very good for demonstrating. But the disadvantage of having a well pneumatized bone is your suction keeps getting blocked. So and whenever you're doing a temporal bone dissection, try to explore each and every cell of the mastoid. So don't just do one or two exercises and feel that you've completed the temporal bone. In each temporal bone, you have to utilize it to the maximum and try and explore each and every structure of the temporal bone. Because as we all know, getting temporal bone these days is very difficult, and when you do manage to get a temporal bone, you have to do everything from myringotomy and grommet incision all the way up to the internal acoustic meatus, carotid, jugular bulb, everything you have to try and explore. And even while doing a cortical mastoidectomy, don't try to just open the antrum. Try and visualize the entire anatomy of the temporal bone, see all the structures, and once you're well versed with all the structures, it will be much easier for you when you're doing a surgery. In case you encounter an extensive disease, you know exactly where you can drill and where you can't drill, because you would have practiced on a temporal bone. So some important things you need to keep in mind. Whenever you're close to any important structure, you need to look out for change in color and change in tone of the burr tip. So those are very important things that you need to keep in mind. I will show you what I mean by that. Hello. And if any of you have any questions at any point, please feel free to ask. And also, as beginners, you may be scared to open the mastoid, and what you'll end up doing is you'll try to make a very small opening. But making a small opening is more dangerous than opening it wide, because when you're making a small opening, you don't know where you're drilling and you don't know where the surrounding structures are. But if you make a wide opening like this, then you'll be able to know where you're drilling, and you'll see the 360-degree rotation of your burr tip, and that is very important in order to avoid any complications. And another important tip is your antrum will be almost at the level of the middle ear. So in case you encounter a corner septum, or you're not sure if you've already reached the antrum, hello? Yeah, thank you. So in such cases, you can always compare to the level of the middle ear, and it will be almost at the similar level to the mastoid antrum. So now you can see this is the mastoid antrum there. So I am slowly trying to widen the antrum, filling out the posterobony meatal wall also simultaneously, and also drilling towards the tegmen. And another thing which is important to note is, whenever you are drilling close to any important structure, always work parallel to that structure. For example, I know the tegmen will be in this direction. So you need to drill parallel to the segment. So that will prevent accidental injury. So that is also a dictum which you need to remember whenever you are close to any important structure, be it the facial nerve or the sigmoid sinus or the dura, always try and drill parallel to that structure. So now you are seeing this is the antrum here, and let me just, this is the lateral semicircular canal. You can see that solid bone there. So this is a very important landmark that one has to always visualize when you open the antrum. You see the lateral semicircular canal. So I was talking about the change in sound. I don't know if you can hear this, but let me just show you. So this is the normal sound which you get when you are drilling a solid cortical bone. But here, the bone here is quite thin towards the tegmen. You can hear a very high pitched tone when I'm drilling here. Can you hear this? So this gives an indication that you're close to the tegmen. Can you hear this very high note here? So this you always have to keep in mind, the change in sound. This is the normal sound. This is the high pitch sound there. So that gives an indication that you're close to some important structure. In this case, you're close to the tegmen. And the same thing you get when you're close to the sigmoid sinus. Another thing is the change in the color also, which is the more prominent when you are doing live surgery. And also you need to look out for bleeding. Whenever you are close to an important structure, you will encounter some amount of bleeding there.
Dr. Dean,
Yes, sir.
just please show the spine of Henley, because you made a very good point for the juniors.
Yes, sir.
And how the important structures are above the spine of Henley.
Yes, yes.
This is the right movement.
Yeah. So it's not very prominent in this bone, but generally it will be somewhere here where I've kept my suction tip.
No, it can be appreciated. It's slight.
Yeah, very slight bulge, but
Right.
sometimes it's more prominent, and it's easier in such cases. So when you stay superior to the spine of Henley, you will reach the antrum here. But if you go inferiorly, you'll keep looking for the antrum, and you'll get a solid bone here of the lateral semicircular canal, which you may miss, and especially for beginners, you might end up drilling the lateral semicircular canal as well as the second geno of the facial nerve.
Beginners,
Yes, sir. Yes.
sometimes it might happen that during breeding you enter into a large mastoidectomy cell.
Yes, yes.
How you will be identify the auditors. You are sure that the antrum, the cavity is communicating
Yes, sir.
with the medullary cavity through auditors, then you can be sure that definitely it is mastoid antrum.
Yes, sir. Yes. And also if you have elevated the tympanomeatal flaps, you can just check the depth. If they're almost at the same level, then that gives you a clue that that's the antrum. So I'm using a conical cutting bore here just to cover more surface area. So another important principle is your edges should be reverted like this so that you see where the underlying structures are. This is especially true in cases of when you're doing a surgery for colectomy so that you don't leave out any hidden areas. But even otherwise, to have an ideal mastoid cavity, always try to saucerize the cavity like this so that you get a complete visualization of the underlying structures. If you have sharp edges like this, you may not be able to visualize what is below it. So always try to saucerize the edges, and as I was saying, whenever you get a temporal bone, don't just try to do a simple mastoidectomy. Try to open and explore each and every cell of the mastoid. You never know when you may encounter extensive disease extending to all the areas of the mastoid, and in such cases you need to have a good thorough anatomical knowledge to know where exactly you can improve.
Hi, delegate doctors, very good morning. You are seeing Dr. Vinay Vijayendra, son of Dr. H. Vijayendra, who is an exponentially expertised in temporal bone anatomy, and as he said, temporal bone dissection is the mother for or to learn the ear surgery skills. A child first learns everything from mother. The same way you learn intricate anatomy from temporal bone dissection. Thank you.
Very true, sir. So before you do any mastoid surgery, you have to do plenty of temporal bones so that you get confidence, and your senior also should get confidence that you'll be able to do mastoid surgery. Only then they'll be willing to give you the surgery.
When you practice, don't think that you have to do the whole exercise in one day. So you can start step by step. Today you can open only the antrum and this thing, because in your own setup you can use temporal bone to do for few days, procedure by procedure.
Yes, sir. Time should not be a criteria.
Yes.
When you are doing a temporal bone dissection. So you should do it at your own pace.
Yes. Because demonstration he is expertised, so you will be seeing all within a short time. But don't think like that. When you get a temporal bone, dry or wet, do exercise at your own learning skill and speed. You have to observe the types of burr tips, means breed bits, what Vinay is using. Initially he has used the teeth of the distance of the teeth, distance between two teeth. It gives the speed of cutting tendency.
Yes, sir. That's a very important point. So the lesser the number of teeth in the burr tip,
Yes.
the faster it cuts.
Cuts, yes. Don't think it's inversely proportional.
Yes. For
The
example,
number of teeth is less, cutting speed and cutting bits are more.
yes, sir. For example, here the left side has lesser number of teeth.
Yeah, yes,
So this will cut much faster than the one on the right.
yes.
But the one on the left is also more dangerous, especially when the beginners are using. Suddenly it may cut into some important structures. So you need to be careful where you use the drill bits, and in every situation you have to use the appropriate size of the burr tips.
Another small hint in selecting the drill bits. Usually they get 70 mm in length. But if you use 60 mm, the bobbling tendency will be very less and it will be more sturdily fixing to the handle. So lesser the length, like 60 centimeters is also good. These are all only 40. These are short length drilling bits.
Yes, sir. So the stability will be more if it's
Stability will be more.
smaller.
Mainly this is used major drilling work to remove the majority of the bone and exposure.
So again, I'm expecting the sigmoid sinus in this area.
This bone is highly pneumatized, so we have to drill and expose a lot of bone all around.
Yes, sir. So generally, when we're doing surgery, it will be more of a sclerotic mastoid because they would have come with chronic ear disease. So this much of pneumatization will not be there in such cases. But these bones are good for demonstration because you can explore each and every cell here.
So if you want to select, pray God that I should get a good pneumatized bone for drilling exercise, so that you can see more anatomical landmarks.
Yes, sir, correct, sir. But another disadvantage of a sclerotic mastoid which we see in chronic ears is the landmarks will be difficult to identify, especially sometimes it is completely sclerosed. You'll find it difficult to open the antrum. The sclerosed mastoid will almost look like the semicircular canals. So in such cases you have to be very careful, try to find one cell and then slowly try to extend it so that you don't accidentally damage any critical structures.
Vinay, do you do any CT scan study for this cadaveric demonstration bones before subjecting to exercise?
No sir, I have not done.
So that we can know what is whether it is a pneumatized or a sclerotic. Number two, you can correlate your temporal bone anatomy of CT scan and correlate on-table cadaveric dissection.
Yes.
Have you encountered perforated ears in cadaveric dissection?
Yes sir, many times, but we don't know if it is
Dry or diseased or something?
if it was actual diseased or during the process of pouring the cadaver, it might have.
Really extensively pneumatized. We can see the lower part towards mastoid tip going almost 1.5 centimeters down to the floor of the external auditory canal.
Yes sir, that's a very good point. You can see the level
See
of the,
what is the level of the EAC floor and what is the level of mastoid tip. It should become a consteatoma. When you reconstruct with soft, you have to do enormous amount of soft tissue filling to make the drainage of the cavity much better.
yes.
Good morning, sir. Manideep here. It's again wonderful to see you play with the temporal bone. It's like Picasso playing on his canvas. You are a beautiful sculptor.
Thank you, Dr. Manindra.
For beginners, so how to identify the difference between the mastoid and the petrous bone? Because all the landmarks lies in the petrous bone.
Yeah.
Visual cues, can you just enumerate, sir?
So, petrous bone will be a very spongy bone. So when you're drilling, your bird tip almost sinks into the petrous bone there. And that will be much deeper. So it's very rare that you come across the petrous bone.
And also, when we are drilling the mastoid part, it will be, all the cells will be like a honeycomb appearance.
Yes.
But the petrous will be a smooth, dense, yellowish, pearly white.
Correct.
That's when we can identify the lateral semicircular canal.
Yeah.
I think which will be in a banana shape.
Yeah. You can see the mastoid tip is going so inferior and so deep here.
Even to identify the digastric ridge,
Yes, sir.
I think we are going much down in this.
Yes. So again, digastric ridge, like sir said, is a very important landmark. to identify the facial nerve. So the tip cell has two groups. Mastoid tip cells has a medial group and a lateral group. This is the lateral group of tip cells. Here there are no important structures and you can easily drill here. And once you get the digastric ridge, whatever is medial to that will be the medial group of tip cells. No, it's blocked. And this is the digastric ridge now. You can see this prominence here. This is the digastric ridge. And this is a very useful landmark to find the facial nerve. Sometimes the digastric ridge may not be very prominent in such case, or you may accidentally drill it out. In such cases, a useful landmark is the digastric muscle. So you keep drilling here, you can see the soft tissue. This is the digastric muscle. And this muscle you can never miss, because if you keep drilling inferiorly, you will end up finding the muscle. And then you follow the muscle like this, you will find the digastric tendon. You follow the tendon, you will find the facial nerve. So that is another important point. This is the digastric muscle. You can see it very nicely here after drilling the lateral and the medial group of tip cells. The digastric ridge is a very useful landmark as it points towards the vertical segment of the facial nerve. And even if you miss the digastric ridge, you can find the digastric muscle, which is this soft structure here. You can see it is going inside when I push it. So follow the digastric muscle, you will find the digastric tendon. Follow the digastric tendon and that will point towards the facial nerve. So I'll just come back to the facial nerve later. Now you can see the shape of the cavity here. You can see this bulge, which is the sigmoid sinus. Let me completely delineate the bulge of the sigmoid sinus. So as the bone is quite thin now, I will switch over to a diamond burr tip. So you should be careful whenever you are close to any structure, always drill with a diamond burr tip, and also work parallel. Like I told you earlier, always work parallel to the structure. So you can see this is the sigmoid sinus here. You are getting the, you can see the bone collapsing here. There is a thin bone over the sigmoid sinus. So I am working parallel to the sigmoid sinus. So it is important to identify all these structures when you are doing the temporal bone dissection.
When always see like a golden speckle.
Yeah, I think most of the tips have got a coarse, but I think this is a...
This is smooth.
Diamond. I think this is also coarse, but it has become smooth.
The advantage of coarse diamond is it cuts more than a diamond and it is safer than a cutting burr. So in vital structures, when you are using a cutting burr, beginner can dip in and injure whether nerve or sigmoid sinus. But with the coarse diamond, you can slowly grind it actually. The coarse diamond grinds instead of cuts.
Correct.
So the beginner should always have this in his arsenal, so that whenever you are close to an important structure, you can shift to coarse diamond instead of a cutting burr.
Yes. And whenever you are doing temporal bone dissection, always try to have all the instruments that you will use for a live surgery. So you always have to imagine that you are doing a live surgery and give utmost respect to all the structures even when you are doing a cadaveric dissection. So now you can very nicely see the shape of the sigmoid sinus here. And here this region where the tegmen and the sigmoid sinus meets, this is the sinodural angle, because this will be the dura, this will be the sigmoid sinus. So that area there is the sinodural angle. So this is very important, especially in cases of cholesteatoma. One has to always open up the sinodural angle. So it has two advantages when you open the sinodural angle. One is there may be some hidden cholesteatoma in this region. So when you open it, you can make sure that you haven't left behind any residual disease. So that is the first advantage. Second is when you're doing the cavity obliteration, usually we use post-auricular soft tissue. So when the sinodural angle is open like this, it ensures that there is adequate soft tissue collapse into the cavity. So your post-operative cavity obliteration will be much better if the sinodural angle is opened and the soft tissue collapses completely into the cavity like this without any restriction. So you can see this is the sinodural angle. Again, a very important hidden area. You can see how much I opened this. So sometimes you may leave behind some cholesteatoma, especially in extensive diseases. We see cholesteatoma in this region in many of the cases. So it has to be made smooth and uniform like this.
And you can see always whenever sir is going towards hidden areas, he goes from lateral to medial, so that there are no hidden areas in the medial part of the bone, and you can see it directly. This is a very important point while drilling. You have to always go from lateral to medial in order to not have any shadows or obscuring the lateral bone.
Very true, very true. And also you saw I was rotating the bone constantly. So even this is something you need to do. Even when you're doing the live surgery, you need to keep changing the position of the microscope. You can also move the chair depending on where you're working. If you're working towards the tip, you can move higher up. And if you're working more towards the tegmen and the epitympanium, you can move your chair more inferiorly. And you need to keep changing the position also, so that you have complete 360-degree view of wherever you are drilling. And here you can see this is the dura and the tegmen there. This is the sigmoid sinus. I've just left a thin bone over it. You can see the lumen of the sinus here. Sorry.
The concept of having big mastoid cavities is now totally changed. Previously, because of that cavities, weeping, warping and wiping. 3 W's were there. The patient used to go on wiping and causing weeping cavities. Now, the superior and inferior pedicle flaps, they are totally obliterating the cavity, just looking like a normal external auditory canal. In such cases, what Vinay is telling, you have to expose each and every cell to know any lurking hidden cholesteatoma pathology.
Actual textbook definition of a cortical mastoidectomy is the complete exenectration of all cells, be it retrosigmoid, be it tip, medial, lateral tip cells, the retrofacial cells, everything. But in clinical practice, once we see the patency, we stop at that level and we do not completely exenectrate unless until it's a attic disease or cholesteatoma, squamous cell disease.
I think, Vinay, we are able to see the body of the incus.
Incus, yes sir, yes, that's what I was.
And the small ridge of bone above.
Yes sir.
And incus in the short process fossa of the incudis. From there you can see the banana curved lateral semicircular canal.
So now you can see through the antrum, this is the incus. So you can see the movement of the incus also. So this is also something we can do once you open the mastoid. You can go up to the incus, just palpate, look for the mobility, and then you can stop.
Usually cholesteatoma goes medial to the incus first, or even sometimes lateral to the incus, Vinay?
We see both, sir, both medial and lateral.
the space medial to incus will be more
Yes, yes,
rather than the space lateral to the incus.
yes.
But in retraction, wherever there is a small area, the pathology goes on spreading to that small recess.
Correct. If it goes medial, it is more difficult to remove in
Yes.
toto. So
Yes.
that is another important thing. So in that case, we may have to do a canal wall down in such cases where it is going medial to ensure complete clearance of the disease. So next I will do what we call epitympanotomy. So to do an epitympanotomy, we drill all the cells here, go up to the root of the zygoma and drill between the posteroboniatal wall and the tegmen here. So that is called epitympanotomy. So this epitympanotomy is also a very nice exercise that all of you should practice. So by doing an epitympanotomy, you will be able to visualize the body of the incus and the head of the malleus in the epitympanum from the mastoid side. So you have to drill in this direction here.
Please observe very carefully
And
epitympanotomy.
yes, sir.
So sir starts from the root of the zygoma and comes down in between the tegmen and posterior canal wall. The space where sir is drilling will open up the aditus and posterior attic. So that's why it is called epitympanotomy. This is a very crucial step in for tympanosclerosis surgery and also for cholesteatoma surgery.
Yes, yes. So this has mainly 4 indications. One is in cases of extensive granulations. So sometimes there will be extensive granulations, especially we still see a lot of cases of tuberculosis. So there will be extensive granulations around the iron joint, the incus and the malleus. So the main aim of doing this epitympanotomy is clearance of the disease without disturbing the normal ossicular chain. Because whatever reconstruction you do, it will not be the same as retaining the normal ossicular chain. So whenever possible, you have to try and retain the normal ossicular chain. So for that purpose, this epitympanotomy is a very useful exercise. So when there is extensive granulation around the iron joint, you can do this epitympanotomy like this. I'll just expose a little bit more. Only thing is, you need to be very careful when you're drilling here, because like I said, the aim of this procedure is to retain the normal ossicular chain. So if you drill the ossicles or accidentally touch the ossicles, then you'll end up with disarticulation of the ossicles. So the whole purpose will be defeated. So you need to be very careful, and you have to practice a lot in cadavers before you try this. So you can see the bony ledge here quite close to the incus. I've taken a very small diamond bell tip and slowly drill it. And also your direction of drilling is also very important, because you'll be drilling here. If you're drilling from lateral to medial, there are chances that your bell tip might slip, and if it slips, it is going to go and hit the ossicles directly. So all that you need to keep in mind. I'm drilling from below upwards now, very slowly, trying to create space. And here there will be a very tiny distance, almost at a hairline distance, between the incus and this ledge of bone. So you can very slowly drill it. You can also change the speed of your drilling if you want to go very slowly. But at all times you need to keep in mind that your burr tip might slip at any time. So even if it slips, it should slip away from the direction of the ossicles. So see, I'm putting pressure away from the ossicles, slowly thinning out the bone there, exposing the incus and the malleus.
Head of malleus is in.
Yes, head of malleus.
What's that ligament, Vinay?
I think that's the superior malleolar
Malleolar
ligament.
ligament. You can see very clearly there is a superior malleolar ligament. Up also, Deepu. There is another ligament going to the tegmen tympani. One of the most difficult exercises is epitympanotomy. And if it is a low-lying dura, unfortunately, that is much more difficult because even a quarter of a millimeter makes tremendous difficult to manipulate.
Yes, sir. So that's the advantage of this cellular mastoid. It makes the exercise look very easy, but when you actually come across a sclerous mastoid, it becomes much more difficult.
And sir, was it 1 mm diameter, sir? That you used?
1 mm diamond. So according to the situation, you need to keep changing the size of your birthday. So now you can see, I'll go to next magnification. Yeah.
So this is the superior malleolar
This is the
ligament.
superior malleolar ligament. This is the head of the malleus, the iron joint, which you can see the dark line there, and this is the body of the incus.
And this is the short process.
This is the short process, which is attached to the fossa impedis here. This is the short process of the incus,
This is fossa incus.
body of the incus, iron joint, superior malleolar ligament, and the head of the malleus. So, as far as the indications go, as I was saying, one is in extensive granulations, so that will be fixing the ossicles, and the patient will have a very big conductive hearing loss. So in such cases, exposed like this completely, you can clear the disease around the ossicles without disturbing the ossicular chain. So whatever disease is there, you can take a pick and slowly try to clear all the disease all around 360 degrees in order to make the ossicles mobile. So that is the first indication. And the second indication is in case of tympanosclerosis. We see in most of the cases of tympanosclerosis, there will be attachment between the head of the malleus and the tegmen here. So even for that, you need to retain the normal ossicular chain, try and clear the disease by doing this epitympanotomy. And in case of limited retraction pockets or limited cholesteatoma, you can do an epitympanotomy here and try to clear the retraction pocket in toto and push it towards the middle ear. So that is also another thing you can do. If you just do a mastoidectomy, sometimes the retraction pocket might be extending till here, and you can still reach it if you do a very wide atticotomy from the middle ear side. But this is also a good way to do it. You can do an epitympanotomy, take a cotton ball, try to push it from this side and retain the retraction pocket and remove the disease in toto. And the final indication, we see cases of bony ankylosis of the malleus. So in bony ankylosis, what happens is there will be a bone fixing the head of the malleus or sometimes the iron joint to the tegmen. So almost similar to the superior malleolar ligament which you are seeing, there will be a thick bone here fixing these two. So that will be completely fixing the ossicular chain. So preoperatively in all these cases, we may confuse it for otosclerosis. So there will be a normal tympanic membrane with a very big AV gap. So in such cases, when you do a CT scan, you can find out that there will be a fixation here between the malleus and the tegmen. So even in such cases, we do an epitympanotomy and try to clear the disease. I'll just remove the malleolar ligament just to show how we clear the disease. In case there's any bony ankylosis, you can either drill it, or sometimes if it's not very thick, you can try to remove it with a pick like this. So the idea is you have to make enough space between the ossicles and the tegmen. And when you do that, you'll get normal mobility of the ossicles. So these are all some of the indications. And many times when you do a mastoidectomy, you try to look for patency. How much ever you drill, you may not find the patency. So in such cases, always explore the epitympanum. There will be something, some disease here blocking the pathway here. So if you do an epitympanotomy and clear the disease completely here, then you will definitely get the patency. So these are all the indications, and you can see it is very nice to see also the anatomy of the ossicles. So this is also something that all of you need to practice.
Usually in chronic otitis media with a small CP, and if the middle ear mucosa is hypertrophied, then you should definitely suspect that there are some granulations around the ossicles. Then this procedure will help you in achieving patency instead of doing a atticotomy, which is you drill from here.
Yes, yes.
In conclusion, what Vinay told, the epitympanotomy for 4 conditions. Extensive granulation clearance, especially now tuberculosis is becoming common. Number 2 is cholesteatoma. Number 3 is tympanosclerosis. Number 4 is bony ankylosis. A preoperative CT scan for a conductive deafness, whether it is stapes or this thing, bony ankylosis, CT scan will give you a wonderful differentiation. I think Vinay, 2016, Dr. Vijayendra is conducting a wonderful otology workshop.
Yes, sir. Yes.
This year it is now last week of May.
Last week of May, sir. Yes.
Finnish otology. More than 1,200 delegates come all over the world, and I have learnt very intricate, meticulous, small tips. I am attending right from 2016 till now. All workshops, not even missing a single one.
You make it so interesting, sir.
I am the master of ceremony for all the workshops in Vijayendra's workshop.
Yes, yes, sir.
I think you should carry home message about epitympanotomy. This is a very intricate, delicate, micro temporal bone dissection technique.
So I'm just pulling out all the remaining air cells here.
This forward-lying sinus is always associated with low-lying dura, Vinay?
Yes, many times, sir. Most of the times, yes.
So in such conditions, you don't have space.
Yes, yes.
Sometimes you will have only 1 millimeter of space and you have to make your way
Yes, sir.
going to the anterior part of malleus in such contracted cavities or anatomy is really difficult. Whether you are seeing an open book,
Yes,
a
yes,
beautiful field.
Yes, sir. So now you can see the shape of the cavity here. I can still saucerize the cavity a little bit. Only thing is here this irregularity is because the bone holder has come here. So that is the protrusion there. So apart from that, there is a nice wide cavity with you can see the bulge of the sigmoid sinus very clearly. This is the tegmen area. You can see the digastric ridge also here, and also you can see the ossicles, the malleus and the incus here.
Delegates, if you have any questions, because stage by stage he has come to finish first stage, please be bold enough for asking questions is the mother of getting knowledge.
Please don't hesitate to ask any questions.
Yeah, don't hesitate to ask.
Now I'm just filling out the posterior bone in the wall. So next thing I will be doing is the posterior tympanotomy and also the facial nerve decompression through transmastoid approach. So to do that, first we need to completely fill out the posterior bone in the wall.
So what is the correct size of spur to select while doing any step, suppose for saucerization or after exploring antrum towards vital structures?
Yeah, so to be very honest, we don't look at the number or anything. So we have this whole stand here. So we pick whatever is appropriate for that situation and use it. So many places they ask the assistant or the nurse to pick up the burr tips and give them, they say, bigger or smaller burr tip, but we prefer choosing the suction as well as the burr tips ourselves. So it will be right next to us. So the burr tips and the suction will be handled by us depending on the situation where we are working. So now you can see this white shadow which you're getting. This is probably the facial nerve.
So sir is drilling anterior and a little bit medial to the digastric ridge. So that, yeah, you can see
You can
in the
see the
depth.
shadow here.
Yeah, shadow.
That whitish shadow which you're getting is the
This is
facial
the
nerve.
facial nerve.
And you can see how it is corresponding to the digastric.
Digastric. It's anterior and medial to the digastric.
Yes, yes.
what Dr. Vinay is telling is always it is a individually based targeted selection of drill bits. We keep all the market in front of you and select the product wherever you feel like.
Yes, yes. You can see it is always very consistent, this digastric ridge and the facial nerve.
Suppose if the digastric ridge is lost, as you said, sir.
Yes, yes.
So another landmark to find out facial nerve would be the fossa incudis.
Fossa incudis, yes. So I'll show that also. I'll just try to trace the nerve a little bit and I'll try to come from that side also. So you'll know both the ways of identifying the facial nerve. So when you're close to facial nerve, always use a diamond bite. And I'm working parallel to the direction of the facial nerve. You can see the facial nerve is going like this, always work parallel. So that is a universal principle in temporal bone. Whenever you're close to any important structure, start working parallel to it.
And also the facial nerve will travel superiorly once it comes towards tip.
Yes, yes.
It goes, it's not like a straight line.
Correct, correct.
Medial to lateral, it goes superiorly. So that's why for the digastric ridge, it is immediately anteromedial to digastric ridge.
So then always use diamond, it is always safer. And the pressure also you need to keep changing. When there is solid bone, you can use more pressure. Even with the diamond, when you are close to the facial, always try to reduce the pressure. So don't press too much, just gently polish the bone there.
I always think why God has made the most circuitous route for facial nerve among all cranial nerves.
Yes, yes.
Even so many curves, he would have put a small hole like facial foramen and put down into the skull base and it will supply the face. It is taking labyrinthine curve, first genu, horizontal, second genu, vertical part, chorda tympani. That is making all of us worried about facial nerve.
So a little confusing here because this looks like some fibers. Actually, the facial nerve.
Can you show with the ballpoint suspected area of facial nerve?
Yes, sir.
So that the beginners will know how it looks like.
So this is why you always have to be careful and suspicious and use diamond always.
Point out the fossa incudis, lateral semicircular canal and suspected facial nerve bulge.
So you can see the short pose of the incus. So that is a very good landmark for the fossa incudis.
Yes.
The fossa incudis is that part where the short pose of the incus attaches to the posterior bone immunity wall. So this will be the area of the fossa incudis. And so one way is to identify the facial nerve from proximal to distal. That is from the fossa incudis, do open posterior tympanotomy. Through the posterior tympanotomy approach, open the facial recess cell and then the medial boundary of the facial recess will be formed by the facial nerve. And you can follow it below like this. Another thing is try to start from the digastric side. So you can see, so I was drilling here, there was some soft tissue, but it's not going in a straight line. You can see it is coming here and then there's some branch here. So that might not be the facial nerve, but when I go a little deeper, this white structure which you're seeing, this is probably the facial nerve.
Yeah, I just want you to make it clarity.
Yes, yes.
For a beginner, even the anteriorly based two fibrous strands look like facial nerve. That, oh, it must be facial nerve. Anteriorly another strand is there.
Yes, and it was quite wide also in diameter.
Yes,
so
yeah,
it's almost
quite
looking like the facial nerve.
So you have to trace from fossa incudis, posterior tympanotomy, medial boundary of posterior tympanotomy, facial nerve will run.
And I was telling you about the digastric muscle also. So this is the digastric muscle here.
Okay.
This
With
is
that you show the relation of facial nerve.
Sir, if we injure, will there be any torticollis, sir? Because they usually...
no, digastric muscle usually nothing will happen. The only thing, there will be a lot of bleeding when you touch the digastric muscle that you need to cauterize. So that's not a problem. So digastric muscle will end with the tendon, and you can see it is exactly continuing here. So in terms of the depth, I think the digastric muscle and the tendon is a better indicator than the digastric ridge here. So you can see here, this is the facial nerve. So I'll continue drilling here, or I'll come from the facial recess approach so that you can learn both the ways of identifying the facial nerve. So in case there is any confusion in one direction, you can always come from the other. So you can, now I've opened from the digastric side, and in case you don't get the facial nerve or there's a little confusion because of the soft tissue, you can always start off from the facial recess side and come from proximal to distal. So here also you need to thin out the bone completely.
This is the LSSC, this is the incus. So facial nerve usually comes in between.
Dr. Vijayendra?
Yes, sir.
Then how do you account for this soft tissue that is mimicking the facial nerve? Is it the chorda tympani? Can it be the chorda tympani?
I think chorda tympani is actually originating here, sir. I'll just show you. There's just some periosteum or some fibers like that. So this is the origin of the chorda. So this is the facial.
This is the chorda.
This is
Right,
the
right,
chorda.
right,
But
right.
these are just some periosteum or something like that.
Something like that. Okay, thank you.
Yes.
So once again, sir has changed his handpiece direction. He's drilling parallel to the canal wall. So these are very important for beginners to change their handpiece directions when reaching a certain landmark.
So try to make it as thin as possible, the posterior bone in your two wall, so that it becomes easier for you to open the facial recess cell. I think this is 2.5, sir. But it's becoming a little big there, so I'll take a slightly smaller one. So now to open the facial recess, you have to always make sure that you don't accidentally damage the lateral semicircular canal, which is very close by, and also the medial boundary of the facial recess is formed by the facial nerve, so that also you need to be very careful. So the facial recess cell is a small cell which will lie about 0.5 millimeters inferior to the attachment of the soft of the incus. So somewhere here, and we already know the level of the lateral semicircular canal. So just above the level of the lateral semicircular canal, you can just keep drilling the bone here. Sometimes there will be a very prominent facial recess cell which you can easily identify.
and sometimes it needs a little bit more of drilling. So this facial recess approach is very useful to identify the facial nerve, one thing, and the other thing is nowadays the cochlear implants which are being done. The facial recess approach or the posterior tympanotomy is very useful to identify the round window and do an implantation. So these are the two main indications for the facial recess approach.
Sir has opened up the facial recess cell.
So slowly extend it after you open it. So can any of the postgraduates tell me the boundaries of the facial recess? Anyone?
So the boundary of the facial recess, anteriorly you have the chorda tympani, posteriorly you have the facial nerve, and posterior superiorly there is the fossa incutis.
It should be lateral, medial, superior and inferior. Okay. The laterally is a chorda tympani, medially is a bony facial canal, inferiorly the origin of the chorda, and superiorly is the fossa incutis. Okay, the anatomical you are telling correct, but it should orient yourself. Okay, good. Your name please?
Once you have opened up this cell, slowly you have to drill from superior to inferior to completely expose the entire facial recess.
I think probably that is the chorda. I have accidentally drilled it. That is the lateral boundary. Here you can see the chorda. Lateral boundary is the chorda. Immediately, slowly keep drilling till you see a change in color. You will see the shadow of the facial nerve. So again, try to use only diamond in this region because all around there are important structures. And now we are also seeing the stapes. So I'll come back to that. Let me first identify the facial. So drilling very slowly, not applying any pressure. And you can also see the staples and also the pyramidalis process. So that is a very good landmark for the second geno. The patient now takes a turn at the level of the pyramidalis process to continue as the second geno. Yeah, now we've got the shadow of the facial here. This is the facial second geno.
It's exactly in between lateral semicircular canal and incus.
And now you can see it is continuous with the facial nerve which I identified earlier from the digastric. And this is the chorda tympani. So you can trace the chorda also.
Yes, sir. Can we see nerve to stapedius also, sir?
Now to stapedius, I'll have to maybe learn by this.
Yes.
We have to lift the facial nerve at the second genu area, and that will be medial to the second genu. Now you can see the facial recess. This is the medial boundary which is bounded by the facial nerve. Laterally you can see this is the chorda tympani here. So laterally chorda tympani, medially facial nerve, superiorly the fossa incudis. And
This is stapedius tendon.
yes, this is the incudostapedial joint here. You can see this is the incus, this is the IS joint.
Ah,
Yeah, you can see the IS joint. This is the pyramidalis process. So you can see this triangular piece of bone, that is the pyramidalis process, and the stapedial tendon which is arising from the pyramid. So here, sir? Yes, yes, sir. Promontory. And can anyone tell me what this bone is?
Sibiculum, sir.
Yes, yes, correct. So this is the sibiculum. So sibiculum arises from the styloid eminence, goes up to the promontory. So very prominent in this case, this is the sibiculum.
Which oversees round window.
Yes. So you can see this is the round window there. This is the round window. So here this is a very useful exercise to do a cochlear implant also. Here I still need to expose the facial nerve a little bit, but I'll come from the horizontal segment there because the nerve is already exposed here. I can't drill more. So once again I'll just show you, this is the digastric ridge, digastric muscle. You can see the facial nerve, shadow. I still have to remove all the bony pieces here. This is the origin of the chorda tympani, and this is the lateral semicircular canal. Now to trace the facial nerve completely, it is better to disarticulate the incudostapedial joint and remove the incus, so that I'll be able to go to the horizontal segment, geniculate ganglion, and I'll try to reach the labyrinthine segment also through this transmastoid approach. So what I'm going to do now is I'll disarticulate the incudostapedial joint. So again you can do this through the posterior tympanotomy that you have done. And when you are disarticulating the IS joint, always try to work parallel to the stapedial tendon. The stapedial tendon will give a good counter pressure. So work parallel. Now it's disarticulated. And I'll just remove the incus here. you can, I'll just show you the anatomy of the incus also. So this is the short process of the incus, this is the body of the incus, this is the facet for the inclutomalar joint, long process of the incus, this is the lenticular process, and this is the IS joint. So we need to identify and enjoy the anatomy little by little, all the structures you have to see. Malleus also I'll just remove it just because it is easier. So when we are actually doing a decompression in a live patient, we amputate the neck of the malleus and try to retain the handle of the malleus. Yes. I think that this is coming in the way. I'll just try to. So now you can already see the horizontal segment of the facial nerve. This will be the horizontal segment of the facial nerve. So what I'll do now is I'll remove the fossa incudis so that you have a clear visualization of the rest of the facial nerve.
Sir has removed fossa incudis and incus buttress to completely view the horizontal part of facial nerve.
Now this is the horizontal segment of the facial nerve. Most of the time there may be dehiscence in this segment of the nerve, but in this case there seems to be a hard bone there.
So why that is important is whenever you are trying to remove granulations in a live surgery, if you use sharp instruments and poke medially, there is a chance you can injure the nerve.
Correct. So again for the dissectors, what is this structure here? Can you see this bone? Anybody?
Processus cochleariformis.
Yes, that's correct. This is the processus cochleariformis, and you can see the tensor tendon here attaching to the neck of the malleus. So this is the tensor tendon, processus cochleariformis, and if you look here, you might feel that the facial nerve is going in this direction, but this is actually the canal for tensor tympani which is going here. The facial nerve will actually go more superior and medial in this direction. So I'll show you the relationship there. So the best way to identify the geniculate ganglion is to fracture the processus cochleariformis. You can see this is the processus cochleariformis. This is the horizontal facial nerve. What I'll do is I'll just keep a side knife here and fracture this processus cochleariformis. Can you see? This is almost like a cap here sitting on the facial. So just push that away. And what you're seeing here, that is the tensor muscle, what I'm pushing away. This is the tensor muscle in the canal for tensor tympani. This canal is the canal for tensor tympani. And the facial nerve on the other hand, you can see is going here. So there's a very thin layer of bone on the facial nerve. I just need to remove all that slowly. So these areas you don't even use a drill here. You can just slowly remove it with your instrument. Here the tegment is very thin and there is no dura, so you can see I've breached the tegment there. Even without drilling, with just the instrument. And also I'll come in the reverse direction to identify the horizontal segment of the facial nerve. So all this bone can be easily removed with a side knife or a round knife, and sometimes if it is very thick you can also use a curette. It is much safer than drilling directly around the facial nerve, especially in these areas where the bone around the facial nerve is usually quite thin. You have to be very careful. But here you also have to keep an eye out on the stapes. So this second genu area is the most tricky because there is very limited space and you are working exactly between the facial nerve and also the lateral semicircular canal. So I am not using any pressure and you have to be very careful. So if you try to push this like this, your instrument will go and hit the stapes. So you have to be very careful, very gently try to separate the bone here. So now you can see I have exposed the horizontal segment of the facial nerve and coming close to the second genu area. So this is the lateral semicircular canal and I am separating the facial nerve from that. Can you see here? And here the facial nerve will take a turn and continue into the labyrinthine segment. So again, very thin bone, I am only using blunt instruments, so there is no chance of damage to the facial. Now only this small segment I have to very carefully drill out between the horizontal segment and the second genu. It's quite thick here and yeah, now I think it's actually coming out. Only thing I'm a little scared about the stapes. I'm using a lot of pressure, so I better stay away from the direction of the stapes. So you need to take your time and slowly try to decompress the entire nerve. Now here I have still left a thin layer of bone here. So that is another thing you need to keep in mind. Always try to retain a thin layer of bone till the end and then use these blunt instruments to remove the bone. So it's always safer rather than drilling through and through. So I made it thin with a drill and now I'll just use a side knife or a round knife to remove this bone to expose the facial nerve. So by doing this you are avoiding accidental injury to the facial nerve. Of course when it is slightly thick like this you can always use a curette. So again the posterior end of the curette is quite blunt, so even if it is touching the nerve or sitting on the nerve, it does not cause any damage to the nerve fibers. Try to expose the nerve at least 180 degrees all around to do a good decompression. So now I'm happy with the decompression.
Any people can tell what are the indications for facial nerve decompression? The learning should go hand by hand. Anyone please?
In trauma cases where like facial nerve palsy is there. Shruti Agarwal. Post mastoidectomy cases where facial nerve palsy within 72 hours.
Anyone? So the traumatic cases, facial nerve compression, complications of CSM. Any other? We can all proudly say there is one more indication added to the list, and it has been popularized by the person who is doing the dissection and his father. It's a proud moment for all of us Indians that they have done extensive research on facial nerve, the thickness of the sheath, and so even they're doing for Bell's palsy, unrecovered Bell's palsy post 6 months. They're doing facial nerve decompression and giving good results. So this is another indication added by Vijaya ENT Care Center.
Thank you very much, Mandeep. So yeah, we have a lot of cases
A big round of applause for sir.
of unrecovered Bell's palsy. So most of the patients of Bell's palsy, they recover with the medical line of management, but in those patients who don't recover even after medical line of management, if you don't do surgery, they'll remain with facial palsy throughout their life. So in such cases, we do a facial nerve decompression to relieve them of their facial nerve palsy, and we got very good results, and we've also published in one of the European journals. No, R.F. Cooper Award I got for measurement of facial nerve sheath in different segments of the facial nerve. So now you can clearly see this is the horizontal segment. I hope it's clear. I'll go to next slide.
So Vijay sir, can you please tell something more about your paper, that sheath and just a little bit of
Yeah. So next I'll be incising the sheath. So that time I'll just show the thickness of the sheath and I will explain, sir. So now you can see this is the horizontal segment. This is the geniculate ganglion, and I will just lift the nerve. You can see the nerve taking a turn here. So this is the first genu, and then the nerve is going down into the labyrinthine segment. I just remove a little bit more of bone. Yeah, can you see this? This is the labyrinthine segment. This is the turn here, that is the first genu. I'll just lift the nerve like this so you can see better. I'll remove this small bit of bone.
it takes a 90 degrees medial dip down. So that's how you can identify the labyrinthine segment. So this is horizontal and it is taking a 90 degrees medial dip. This is labyrinthine.
Yeah, I think now you can very clearly see that. So this is the first genu where it's taking a turn, and this is the labyrinthine segment. So labyrinthine segment is the shortest and the narrowest. Now you are able to see very clearly this is the labyrinthine segment, the first genu, geniculate ganglion, and here I'll also show you the GSPN. So this is the GSPN here. You can see one branch going here, arising at almost at the level of the first genu. This is the greater superficial petrosal nerve.
Can anybody tell what is the function of GSP, PGs?
Yeah, here it is very clearly seen. I'll just drill out a little bit of bone there so it's more clear.
It is for lacrimation. So why this is important is, whenever we are doing tests for identifying facial nerve injury, we have to do a Schumann's test. Why it is useful clinically is, if the Schumann's test is positive, then the lacrimation is good. If it is negative, then the lacrimation is not there. That means the facial nerve has been injured up to even the anterior part of the geniculate ganglia. So you have to decompress from vertical segment to second genu horizontal part. So this will help you during surgery for doing Schumann's test when you see a facial nerve palsy.
Yeah, so it helps in the localization of the lesion.
Yes.
So if the lacrimation is absent, it means that the lesion is proximal to the GSPN. So this GSPN will be affected. If lacrimation is present, then it will be distal to the GSPN. Now you can see this branch here, this twig which is going, this is the GSPN, very nicely seen. I'll try to hook it. Can you see this? I've hooked on to the GSPN. This branch is the GSPN which I'm hooking here. You can see it arising from the facial nerve. This is the GSPN and it almost goes in a small canal there and it joins the middle cranial fossa. You can actually see it joining the middle cranial fossa also. This is the dura here. You can see how it is piercing the middle cranial fossa dura. Very nicely seen here. A very nice bone also, sir. I'm able to show all these structures.
Kudos to Kantigos sir for giving an excellent.
It's not easy to get good bones nowadays. And now you can see the bend of the nerve also. You can see that here you can see. So this turn is the first genu and everything below that is the labyrinthine segment. You can see how it is standing. So that is the first genu and the labyrinthine segment. The labyrinthine segment of course is the shortest and the narrowest segment of the facial nerve. So it is also called the bottleneck. And now I'll just incise the sheath. So sir was telling about the difference in the nerve sheath measurements. So I've done a study on the thickness of the nerve sheath in each segment of the facial nerve, for which I won the R.F. Cooper Award. So I've noticed that the thickness of the sheath over the vertical segment is the thickest, and as you go more proximally it becomes more and more thin. So you can see there's multiple layers here in the vertical segment. I'm using this instrument which is called a tenotome. You can see it has a beveled edge, sharp edge here, and posteriorly it is blunt. So I'm incising the epineurium or the facial nerve sheath. So the sheath over the vertical segment will be the thickest. So in the vertical segment, the chances of accidental injury to the nerve are less, because this sheath provides a thick barrier and it provides some amount of protection to the facial nerve, because the epineurium will be enclosed in the sheath. You can see the nerve fibers there. That is the perineurium. So I'm incising the epineurium. You can see the thick epineurium. And as you go more and more towards the labyrinthine segment, it becomes more and more thin. So this is the second genu area where it becomes a little more thin. So to complete our decompression, we always incise the sheath also, because the perineurium will be under a lot of pressure whenever there is any facial nerve injury. So once we incise the epineurium, the perineurium bulges out and the pressure is relieved, and that also helps us to achieve better results.
You can also see the difference in color of facial nerve. Here it is early white.
Correct. That is because of the thickness of the sheath again. Here you can see it is very, very thin, very difficult to get a cleavage to incise the nerve sheath also. So whenever you are dealing with disease around the horizontal segment, you have to be more careful because the protective barrier of the thick epineuron is not there, as we see in vertical segment. Vertical segment, the thick barrier of the epineuron is there. Here it is very thin and it is more prone for accidental injury when you are working near the horizontal segment. And the geniculate ganglia may be more thin, and the labyrinthine segment does not have any sheath. So this is the change in the thickness. Here it is very thin. I am not able to find a cleavage, so I just leave it as it is. But here you can very clearly make out the difference between the epineuron and the periverium. I just try to separate the two. This is just for demonstration. We don't separate it like this. We just incise the sheath and leave it. So just to show you how the underlying facial nerve sheath looks. So this is the actual facial nerve. You can see the perineum very clearly, and the color of the facial nerve also you can see, very nice pink looking.
Very fantastic dissection. Sir, deserves a round of applause.
Thank you, sir. Thank you very much. Thank you.
Sir, one small question, sir. In case of an inadvertent injury or just for the beginners accidentally be injured,
Yes,
so what are the immediate steps we take? We go immediately for complete facial decompression, or we just leave it, or any other what precautions we should take, and what are the immediate measures?
Yeah. So again, that depends on the extent of the damage. So if it is cut through and through and you are sure that there is damage, then better to intervene early, and in such cases we may have to do a facial nerve grafting. So we take greater auricular nerve and do a grafting, and the earlier the intervention, the better the results. If it is just a few fibers which are damaged, then you can wait. You can probably decompress the nerve proximal and distal to it and try to approximate it and leave it. So again, it depends on identification. So if you are very sure that the nerve is transected, then it is better to do a grafting.
First thing is that the beginner should immediately call his senior to help him out in order to prevent further injury.
Correct. And yeah, many times we've been called from other centers and we have gone and done it on the same day. As soon as the surgeon has realized the damage, he called us and we have done it in the same sitting also, because it is a very big damage and there's no way the patient can recover. So in such cases, better to do an early grafting, and they get very good results. Up to grade 2 we get. It won't be complete recovery when we do a grafting. Grade 3 most of the cases, and grade 2 in some cases if done early. So that is the anatomy of the facial nerve now. I hope it is very clear. If the juniors have any doubts, please don't go home with any doubts. Clear all your doubts now. And can I continue, sir? I don't know how much time I have left. If I have time, I will
Anyone can tell the house Bateman classification of facial nerve?
Sorry? Okay, yeah, no problem.
Grade 1 is normal. Grade 2 is able to close the eyes with minimal effort. Then grade 3 is with maximum effort. Then grade 4 is unable to close the eyes with maximum effort. And then grade 5 is who is not able to close the eye at all.
There are 6
Grade
grades.
6 is there is no expression at all.
So I'm just drilling out all the cells around the semicircular canals, because I want to next identify the semicircular canals and also try to identify the endolymphatic sac. We should see if it is there in this bone.
নিচের অডিতে চলে গেছে, একবার চেক করুন ফার্স্ট ফ্লোরে।
So it's very easy to differentiate between the labyrinthine bone and the mastoid air cells. You can see labyrinthine bone will be a thick, solid bone like this without any honeycomb appearance. Whereas here you can see all this honeycomb appearance. All this you can drill out because these are the mastoid air cells. So it's quite easy to differentiate between the two.
And Peter's bone is one of the thickest and dense bones in the entire body.
Yes, labyrinthine bone.
Have you all seen Life of Pi? Life of Pi. So there is a scene in that film where the hero he gets onto an island in between, and the island dissolves all the human matter in the night, and the only part that is not being destroyed is the labyrinthine bone. If you can go back and see, you'll see that beautiful labyrinthine bones in the illuminating light on that scene. So they've shown it in the Life of Pi also.
Nice. I have not watched. I should go and watch.
Yeah. So, sir, can you tell few things about Donaldson line and?
Yeah. So what I'm trying to do now is I'll delineate the endolymphatic sac. So to delineate the endolymphatic sac, one has to completely remove all the bone over the sigmoid sinus and the posterior fossa dura here. So once you do that, you will get the posterior fossa dura, and in the posterior fossa dura you will find the endolymphatic sac. So to identify the endolymphatic sac, this Donaldson's line is a very important and useful landmark. Again, I'll ask the students if they can tell me what is Donaldson's line. Any of the dissectors? What is Donaldson's line? A very important TB question. Anyone?
From the posterior semicircular canal, we'll draw a perpendicular line that will bisect the horizontal semicircular canal, and at the end of this line there will be the endolymphatic sac.
Yeah, partially correct. I'll just tell you. So now I am removing the bone here from the posterior fossa dura and the sigmoid sinus. I have thinned it out completely. You can see this is the sigmoid sinus, and you can see how it is continuous with the posterior fossa dura also. So the endolymphatic sac is a double layer dura. So the best way to identify the endolymphatic sac is to draw an imaginary line called the Donaldson's line. So the first line you draw along the lateral semicircular canal, along the long axis of the lateral semicircular canal, and extend it to the posterior fossa dura. Second line along the posterior semicircular canal. So find the point where these two lines bisect. So the first line is like this, second line is like this, so they're bisecting somewhere here. So just inferior to the point where they bisect will be the endolymphatic sac. So somewhere here. So this is the first line, this is the second line. So somewhere here will be the endolymphatic sac. In this, the dura is not continuous because it's a cadaveric bone. I think it's not fully intact, but still you can see this is the area of the endolymphatic sac. Can you see this whitish color here? This is the endolymphatic duct here. I'll just can you see this connection? So I'm able to push all the dura down, but here you can see one connection here. That is the endolymphatic duct which is coming posterior to the posterior semicircular canal. This is the endolymphatic duct. I'm pushing the dura down, only this area you can see there's an attachment. That is the endolymphatic duct. So the endolymphatic duct continues into the endolymphatic sac. So how do you identify the endolymphatic sac? Just take a sickle knife and incise the dura. So it will be a double layer dura there. Follow the endolymphatic duct. Here of course the posterior dura is not completely intact, but we'll see if we can incise it because there should be some resistance. So this will be a thick double layer dura. So incise one layer of the dura. Can you see this pouch-like opening? That is the endolymphatic sac. Here of course because the dura is completely mobile, I am not able to make a proper incision.
Beautiful, sir.
Can you see this? This double layer dura, this is the endolymphatic sac.
Okay.
So it will be a double layer dura in the posterior fossa dura, and usually it will be more white in color compared to the surrounding structure, so it will be very easy to identify. But more than that, if you can identify the endolymphatic duct, that will only lead you to the endolymphatic sac. You can see this is the endolymphatic duct here. Follow the endolymphatic duct, make an incision in one of the layers, and you see this pouch-like opening, that is the endolymphatic sac. So this endolymphatic sac decompression was earlier very popular for Meniere's disease treatment. But nowadays I think it's hardly done because the results are not very good, very unpredictable. But still it is very useful to know the anatomy of the endolymphatic sac.
I will always get astonished or surprised. I don't know, 500 years back, 16th century, no microscopes, no lights, no telescopic magnified view like this. Dead bodies were stolen from the graveyards, brought, dissection was done in daylight, and I don't know how they identify these intricate small fibers. We having so much amount of huge magnification with Carl's torch, cameras and microscopes, to know that it has a labyrinth segment, to know GSPN, LSPN, chorda tympani, going down, endolymphatic sac, really great. Ambroise Pierre, they used to steal hundreds of bodies, buried down. their retina is having microscopic view. I was heard that they used to keep in front of a window so that even keeping outside to dissect is a very crime at that time. So there was no cremation. All bodies were buried. So they used to go night, take the body out, and they used to do the dissection and gave us this knowledge. And this Gray person, Gray's Anatomy, and he has shown lot of drawings and all these things for us to understand. And still we have to learn all this by doing dissection and know the intricate. And without all these things, they have identified.
Yes, very hard to believe how they
This fellow, vagus nerve from then goes to the anus, and how they identified some 1.5 meter nerve fibers.
Yes, sir.
What I would like to say, we need not feel proud that with all these instruments we are knowing the structures. Without these instruments, our ancestors, without electricity, they have discovered. It's not invention.
And how they drill this hard bone labyrinth to find the
Always it's very surprise for me.
intra-auditory meatus.
And so whole human beings are indebted to those diseased bodies, as well as the dissectors.
Yes, sir.
More than his advanced surgeries, we should thank those anatomists who without any electricity or light and everything, they have dissected every fiber of the human body.
And just for their curiosity to find out.
And they would have taken even, I don't think, in thousands of bodies they would have dissected, not like even tens or...
So now I'm just trying to delineate the semicircular canals. So this is
parallel to the dome of the lateral semicircular canal.
So you can see a bisection shadow which is coming there. This blue lining of the lateral semicircular canal. So labyrinthectomy is done only in extensive diseases which are involving the labyrinth, intra-auditory meatus, and when the patient does not have any residual hearing. So in such cases, you can do a labyrinthectomy and try to cure the disease. And also there is an approach to reach the intra-auditory meatus, translabyrinthine approach to the intra-auditory meatus, which I'll be showing in the end. So right now I'm just trying to delineate the semicircular canals. You can
Are you able to see the lateral semicircular canal membranous labyrinth?
Yes, sir. Yes, sir. And here, just parallel, perpendicular to that, you can see that is the posterior semicircular canal. So the lateral and the posterior semicircular canal lie at exactly 90 degrees to each other. So even if you blindly drill perpendicular to the lateral semicircular canal, you will find the posterior semicircular canal. Can the students tell me which semicircular canal is responsible for which direction of movements and how it is related to balance? So here you can see the anterior end of the posterior semicircular canal is very close to the facial nerve. So that is also an important relationship that you have to keep in mind. Of course, in this case, I've already delineated the facial nerve, so there might be accidental injury here when I'm doing this because we're working in a very narrow area. So I always like to retain the thin bone there and just try to glue line the semicircular canal so that you don't lose the track. In the end, you can always open up the membranous labyrinth. So now I am going towards the non-amplar end of the posterior semicircular canal. So this will go very deep and it joins the non-amplar end of the superior also to form the common crus. Now I'll come from the superior so that I can join both these openings. So here you can see the superior semicircular canal. So superior semicircular canal will be C-shaped, goes quite close to the tegment, and it is deeper compared to the lateral semicircular canal.
The three semicircular canals, we have to imagine the directions of space. We have coronal, axial and sagittal. So all these three semicircular canals will be in these three orientation of space. Even before hearing, the first sensory system was balance only, because every animal has to walk or swim or travel only with balance. Later on hearing has come.
You can see the soft tissue here, this white color. Again, question for the juniors, what is this soft tissue which is in the middle of the labyrinth? Can you see that very clearly?
Yes.
Anyone, any postgraduates?
It is pink in color. That's the clue.
That is the subarcuate artery. There is a subarcuate artery here which will be almost in the middle of the bony labyrinth, and during surgery when you are drilling there you might encounter a lot of bleeding, and sometimes you need to use bone wax to seal that.
See, once again, always the labyrinth bone will be white. Even the tegmen is a little bit darker in color and cellular appearance. So that's where you can identify the border between the labyrinthine bone.
Concrete evidence also is full.
Yes, sir.
Concrete evidence also is full.
Yes, sir. This the superior semicircular canal, I didn't find the proper anatomy. Anyway, I will show you the other two. So this is soft here. Generally it will be more hard. Okay, anyway. So now this will be the ampillary end of the lateral semicircular canal here. This will be the non-ampillary end of the lateral semicircular canal. Here you can see the ampillary end of the superior semicircular canal. Unfortunately, I couldn't find or trace the rest of the superior semicircular canal. It's become very soft and it's giving way very easily, which is usually not the case in the semicircular canals. And here you will find the ampillary end of the superior semicircular canal, and the non-ampillary end of the posterior and the superior semicircular canals will meet at the common crus. Probably this is the common crus opening. You can see how deep it is going. That is probably the common crus structures. already blue lined it, so just very gently I'll just fill it. Yeah, so now you can see here, wash, saline, saline, saline. Yeah. Now you can see the two eyes here. This is the anterior end of the lateral, this is the non-anterior end of the lateral semicircular canal. This is the anterior end of the posterior semicircular canal. This is the anterior end of the superior semicircular canal. Sorry. This is the anterior end of the superior semicircular canal. And the non-anterior end of the superior and the posterior meet here. This is the common crus or the crus commune. So this will be the deepest portion of the bony labyrinth there. Okay. So this is the anatomy of the semicircular canals. So all these semicircular canals meet at open into the vestibule. So next I'll be showing you the vestibule anatomy, and that is also a very interesting and intricate anatomy. So you can see the relationship of the semicircular canals as well as the endolymphatic duct and the endolymphatic sac here, which I have opened. Now I will just drill out the labyrinth to reach the vestibule. Wash. So I'm just drilling along the labyrinth. And here I just try to drill between the anterior end of the lateral up to the anterior end of the posterior semicircular canal. So all this is very hard, solid bone. So hardest bone, so you can see how much effort it takes to drill. Even with the cutting burr, it takes a long time to drill. Now this is the vestibule, what I just opened. This is the vestibule.
You can see all the ampullary ends opening into the vestibule.
Yes, yes, yes. So here you can see an elliptical depression here. in the floor of the vestibule. This whole thing is the vestibule, and I'll go to a higher magnification. So this is a very interesting anatomy which we don't come across usually. So you only read about it in theory and it is very difficult to imagine. But here you can very clearly see this elliptical depression is called the elliptical recess, and the utricle lies on the elliptical recess. You can see the soft tissue here. This is probably the utricle. So these are very delicate structures. Usually it gets destroyed even with irrigation or suctioning. So this is the elliptical recess. The utricle lies on the elliptical recess, and if you see a little more anteriorly, you see a round depression. Again, you can see a brownish gelatinous material here. That will be the saccule. So this is the spherical recess. I'll just try to remove this saccule here. You can see the soft tissue which is there. That is probably the saccule sitting on the spherical recess. So the spherical recess has the saccule. You can see this round depression. I hope it is clear. Okay. This is the spherical recess. This is the elliptical recess. And this bony ridge between the two is called the vestibular crest. This is the vestibular crest separating the saccule from the utricle. So the 5 openings of the semicircular canals all open into the vestibule, and then you saw the spherical recess and the elliptical recess. Next I'll show the round window and the oval window opening into the vestibule. So now I'll just palpate the stapes. You can see the stapes here in the middle here. And when I move it, can you see the movement in the vestibule? The roof of the vestibule. This is the foot plate opening into the roof of the vestibule. Inversely, if I palpate here, you can see the stapes moving in the middle here. So the foot plate opens into the vestibule. The medial part of the foot plate is in the vestibule. You can see the movement very clearly now. So this is the reason why we say you always have to make a fenestra in the posterior part of the foot plate when you are doing a stepidotomy. You can see posteriorly the distance is more. It's more deep and there are less chances of damaging the saccule. But if you go anteriorly, you can see it is quite shallow. The distance, the depth is much lesser. So if you make a fenestra in the anterior part of the foot plate, with the instrument itself, you might puncture the saccule, or when you place a slightly longer piston, that might go and puncture the saccule. But if you stay posteriorly, there are lesser chances of that happening. That is why you always have to make a fenestra in the posterior part of the foot plate. You can very clearly see the movement of the foot plate when I palpate the stapes there. My instrument is in the scala vestibule. So there are 7 openings into the vestibule. It's also very important, very delicate, and it's very nice to see. So now the next thing is, here in the floor are you seeing a brownish structure? So can you see the structure here in the floor of the vestibule? So that is arising from the utricle and saccule. That one branch will be from the utricle, one branch is from the saccule. This is called the utriculosaccular duct, which continues as the endolymphatic duct. So we saw the endolymphatic duct from the mastoid earlier when I delineated the endolymphatic sac. Now the same thing you can see arising from the vestibule. So it is coming like this, it is a J-shaped structure, coming like this, it is going here, and where does it end? This is the endolymphatic duct which I showed you earlier from the mastoid side. This is the sac which I showed, and I continued and I incised the endolymphatic sac. Can you see this was the attachment which was holding the posterior fossa dura in place, which I showed you, and I said this is the endolymphatic duct. So you can see it is arising now from the vestibule, taking a J-shaped turn here, going here, this is the endolymphatic duct, and ending in the endolymphatic sac here. So everything is interconnected. You can see the endolymphatic duct all the way from the vestibule. So I hope that is clear. Any questions? Now the final exercise is I will reach the intra-auditory meatus. I'll just take another 5 or 10 minutes and I'll reach the intra-auditory meatus. So this is the transmastoid approach to the internal auditory meatus. So transmastoid approach to internal auditory meatus is usually done in cases of tumors arising from the internal auditory meatus, or sometimes extensive cholesteatoma extending into the intracoustic meatus, or also in cases of some people do a singular neurectomy in cases of meatus. So even for that you can use this. But the one thing to keep in mind is this is not a hearing preservation surgery, because we will be drilling the labyrinth. So this is usually done in tumors where the hearing is already lost, or an extensive extensive lesion where hearing cannot be preserved, but because the approach you get from this just trying to fix the bone there. Just 1 minute, I'll have to refix the bone because that bone holder was piercing through the dura. So any questions so far? Seen a lot of exercises. I hope it is not very confusing. So there is so much that one can do in a temporal bone. So temporal bone dissection is not about just opening the mastoid or just doing a simple mastoidectomy or a canal wall mastoidectomy. You have to take the opportunity to explore every structure in the mastoid. So you have to spend days together doing dissections in order to be thorough with the anatomy of the temporal bone. Now to reach the intra-auditory meatus, one has to completely drill out the labyrinth and try to expose the posterior fossa dura, the sinodural angle, the middle cranial fossa dura. So everything has to be completely exposed, and you have to drill quite deep in order to reach the intra-auditory meatus. Here the dura is coming in the way. So again, this requires a lot of drilling.
Dear dissectors, after this you will start the dissection, and after some time again Vinay will show you some of the techniques. Meanwhile, you can have a cup of kick with a cup of tea and start your dissection. We are all here. All the faculty are here. You can ask us. We will try to guide you. After the exposure of internal auditory meatus, they will start the exercises.
So the internal meatus has two parts. One is the fundus and one is the porus. The medial part is called the porus and the lateral part is the fundus. The floor of the vestibule, that is the floor which I have exposed here, forms the roof of the IAC. Okay, so that is something you need to keep in mind. The floor of the intra-auditory of the vestibule forms the roof of the intra-auditory meatus. So that is the level of the intra-auditory meatus, and the medial boundary is formed by the porus, which is a continuation of the posterior fossa dura. So the posterior fossa dura takes a 90-degree turn and continues as the dura of the intra-auditory meatus. So intra-auditory meatus will be a funnel-shaped structure. So keep an eye out for any color change now. This is the floor of the vestibule. So immediately below that you'll get the intra-auditory meatus. Only thing, I don't think all the nerves are there in this bone. I already saw in the beginning from behind. I think there was only one or two nerves. Whatever is there, I'll try to identify it. So try to keep pulling it out evenly and try to remove as much bone as possible before you enter the intra-auditory meatus. So by doing that, you will get a wide exposure, and if you get a wide exposure, it will be easier for you to identify the nerves in the intra-auditory meatus. You can see how much of drilling I am doing. Still, there is so much of bone left to be drilled. But when you're drilling here, you need to be careful. Keep an eye out for any color change which indicates that you may be close to the dura. I'm just doing a little faster here because I've already taken up a lot of time. So I'll just finish this in the next 5 minutes. Still no sign of the dura. Like sir was saying, it is very difficult to imagine how they used to drill all this bone. Even with the best of bell tapes and the drills, it takes so much time to drill all this bone here. Now I am seeing the shadow of the intra-auditory meatus. Can you see this blue shadow here? So that will be the dura of the intra-acoustic meatus. So just try to open it wide. Sorry, I'm just doing it a little faster just to finish it. That's the intracoustic meatus. So suddenly the vertebra gave way there. So this will be the fundus end and this will be the porous end. Yeah, I don't think the nerves are there. Can anyone identify this? What is this? Those are maggots. So usually these maggots are very fond of the nerves. So whenever you find maggots, it would have already eaten up all the nerves. So this is the intra-auditory meatus here, and unfortunately there are no nerves. Actually there are few nerves here, some bundles of nerve fibers which are all entangled. Probably the first one which you'll see will usually be the superior vestibular nerve, and I'll just try to open it a little bit more and see, but everything seems to be bundled together. Yeah. This is probably the superior vestibular nerve. So this will be the first nerve that you will identify as soon as you enter the intracoustic meatus, but it's not very clear. So the nerves of the intracoustic meatus are the facial, superior vestibular, inferior vestibular, and the cochlear nerve. So if you divide the intracoustic meatus into four parts, this is superior, inferior, anterior and posterior. So this is the posterior superior quadrant where we are seeing the superior vestibular nerve. This is the only nerve which we are seeing here. This is the posterior superior quadrant. Behind that I am pretty sure we will find the facial nerve, or even otherwise I will just drill out this bone here. We have identified the facial nerve up to the labyrinthine segment in this area. So I will just drill that out to identify the facial nerve. So two nerves will be able to identify in this bone, and after that I will stop. Now I have removed that bone there. You can see this is the facial, and this is the, here we will get the Bill's bar. I will show you. I don't know if it is seen or I have drilled it out. So the easiest way to identify the facial nerve is to cut the superior ampullary nerve at the level of the Bill's bar. So if we cut this, you can see this is the facial nerve and this is the superior vestibular nerve. And the superior vestibular nerve was like this. So this bone here separating the facial from the superior vestibular nerve is called the Bill's bar. So I drilled that out just to show you the entire anatomy of the facial nerve. So now you can see the labyrinthine segment, the bottleneck which is seen there, and earlier I had identified the facial nerve. This is the horizontal segment, the first genu, and till here I had identified from the transmastoid side. Yeah, so this is the labyrinthine segment, and further it is going down labyrinthine segment here, and from here it is the intrameatal portion of the facial nerve. So once again I will show you this triangular piece of bone is the transverse crest. So the transverse crest divides the superior vestibular from the inferior vestibular nerve. Unfortunately here there is no inferior vestibular nerve. This is the superior vestibular nerve, this is the transverse crest, this is the superior vestibular, this is the facial nerve, and I will show you the entire anatomy of the facial nerve once. This is the digastric ridge here. Where did it go? Right here. So this is the digastric ridge, this is the digastric tendon pointing to the facial nerve, this is the vertical segment of the facial nerve. Yeah, this is the vertical segment, this is the second genu area. This is the horizontal segment, geniculate ganglion. First genu, where the nerve is taking a turn. This is the first genu. This is the labyrinthine segment.
Okay.
And this is the intrameatal portion
Of the facial.
Okay, I hope everybody enjoyed the discussion and
Thank you very much, sir.
Very good demonstration.
Beautiful, intricate, detailed dissection. And
Dear delegates, bread and butter, or in our Indian language, roti or sabji, or mastoidectomy, and total anatomy of mastoid. Very spicy festival food, what Vinay has shown, all this labyrinth exposure and everything. So first you master your bread and butter, roti and sabji techniques very nicely, and hope it really very wonderful millimeter to millimeter anatomy, Vinay. You need a very good sound applause from all the delegates for a very good demonstration.
Thank you everyone.
And
thank you, sir.
There is nothing like that, you just have a break and you start, the delegates will start the discussion as per your stations given by lottery.
Thank you, Ghosh sir, once again for the opportunity and very nice facilities and the board also. Thank you, sir. Yes.
you are comfortable. Okay, you sit here only. No, actually she is an observer, so I will just send you to the table 3. With this, sir, Manoj.
Only this is yours, aapka. Everything else is mine.
You just talk to no issue. Or he will come here. Anyhow, he will come.
Thank you, sir. Thank you. This is yours.
आप मैडम
ये आपका. नहीं. मेरा नहीं. हाँ.
ये 2 जन वो डिवाइड कर रहे हैं.
Okay. Thank you. Yes, sir. Yes. Sorry. Sir, thank you. Thank you, sir. Thank you very much.
I know you are very well.
Okay. Thank you.
वही नहीं मनोज जी आप एक मिनट नहीं जस्ट नहीं वो छोड़ने के लिए नहीं ऐसी बात करने के लिए आप लोग कर लीजिए लेकिन हमारी तरफ से कोई दिक्कत नहीं all dissector please take your seats and just if you want a short break take a short break it's up to you and or otherwise you can just straight away start the dissection. The first the one will be dissecting and the other will be assisting.
I am Dr. Madhusudan Rao. Myself Dr. Manidi. We are from Andhra Pradesh.
Sir, say something about the workshop that is going on under the leadership of Dr. Tushar Kanti Ghosh.
Dr. Tushar Kanti Ghosh Foundation is arranging this very dedicated cadaveric dead bones of the ear are given to the students. After getting knowledge in theory, they have practically do millimeter by millimeter dissection to know the intricate anatomy of the ear. So they are going to learn with modern microscopes, drilling equipment, magnification, suction and all the equipment. They will get knowledge to know the intricate anatomy of the ear. Then they will start dissecting or operating in a live dead. So before live surgery, they are going to learn the surgery on dead bones. That wonderful workshop you are seeing, there are 10 stations and 20 to 30 students will learn and get the knowledge of it.
Sir, what do you want to say?
This is a wonderful workshop conducted by So this is a good initiative because before operating and causing any problems to the patient, surgeons should always learn on dead bone so that he will be confident in his skills. In order to give better results to the patient and avoid any complications, these kind of workshops are necessary all over India, and the first step has been taken by Atticotomy sir in arranging with very high quality equipment for the dissectors to do, and we have been called here and we are very happy to come and help Atticotomy sir in
teaching the students. Nothing मैं आपको बताऊंगा कि नेशनल फीवर डॉक्टर जीवन सर जो कि मौजूद है डॉक्टर तुषार कांति घोष के वर्कशॉप में सर की बोलते टाइटल सर आज के कई स्पीच আবার যদি এখানে কাজে করবে তাহলে এরকম ভাবেই ছেড়ে দেবে সামনে যাওয়া যাবে
ফ্যাকাল্টি যারা আসবে এখানে ইংলিশ ফ্যাকাল্টি from Bangalore, from the Andhra Pradesh, from the Bangladesh. I think this is a very important and very exclusive hospital in Kolkata, while all the junior companies get the training from there. Because ENT surgeon must have to know anatomy, basic anatomy of the ear. And the basic anatomy of the ear is known by the cannabis education, without cannabis education, you cannot get knowledge from there. So I appreciate Tushar and his team and all the faculties here and the students who are attending this course. I think it will be fruitful and enjoy what you thank you.
History repeats again and again, sir. Sir, only a few lines. Conclusion, sir.
Now, all delegates from different states, it will be benefited tomorrow. I say here some difficult zone was explored by so tomorrow very simple but very important. Hearing improvement, how the hearing obstacle. So main target is the disease free and hearing. Tomorrow we will medically how tomorrow we will survive.
जब दिल का सहारा बनो तो सही, मेरा जीवन सहारा बनो तो सही। पल पल दिल के पास तुम रहते हो वो कौन क्या है क्या चाहता है भाई तो डॉक्टर सबका भला चाहता है सुबह का की दोस्तों के साथ आप देख रहे हैं लाइव बन अभी आज सबका कनेक्ट होकर बहुत है एक दूसरा सभी लोग पार्टी है इतना करते वक्त के 15-16 बोलते डॉक्टर मतलब इसके लिए मैंने डॉक्टर Thank you very much.
All the dissectors, please take your seats. Wear gowns. We will be distributing the temporal bone. It's just a small notice. The first person who will be dissecting, the second will be the assisting, and when the second will be dissecting, the first will be the assisting. No one will leave the dissection in between. It's not like I have completed the dissection and I will go. You have to both assist, and it's a purely on the lottery basis.
এখন রেকর্ড নিয়ে আমার ডেটা দিচ্ছে আমি বন্ধ করি
पीयूष प्रदीप रोहन सक्शन गुलो कनेक्ट करो कनेक्शन दाओ नीलू ऐसे सोच होएंगे अच्छा नॉट है ना एक्ट दाओ साथ ठीक है टेबल 1 टेबल 1 का लोग कहाँ गए टेबल 2 आप लोग फोन ले लीजिए अभी हम तो सेकंड क्या उनको हम बाद में जो हो जाएगा दिक्कत
কেসটা কি হচ্ছে দেখি ডেটাটা
Take one.
वो हम देंगे
Based on the
टेबल 1 में
इन्हें देखे
आप यहाँ पे है ना मैम
लिस्ट आपके पार्टनर का है
यू टेक वन बोन प्लीज हाँ हम दे रहे हैं आपको সরা এইটা দাও তো দাঁড়া এখানে একটা রাখ এখানে রাখ একটা বোন রেখে দে ये आपका नाम है you will be visiting first this is yours your second we will give later take care of it huh टेबल चल हाँ टेबल 3 एक देवे सेकेंड को हम बाद में देंगे ओके टेबल 4 দাও একটা এখানে দাও রে একটা রাখ না এখানে हाँ रेखे दाओ एक कनेक्ट दो फर्स्ट को हम अभी दे रहे हैं सेकंड को हम जब आप करेंगे तब हम दे देंगे हाँ एक कनेक्ट रखो एक यहाँ के लोग कहाँ हैं आप है ना आप विल बी डिसेक्टिंग फर्स्ट वो विल यू टेक योर बोन आपका हम बाद में देंगे ठीक है अच्छा प्लीज टेक केयर ऑफ योर टेम्पोरल बोन्स बिकॉज इट्स नॉट रिप्लेसेबल अगर खो गया कोई पलट लिया कोई घपच लिया तो आपकी जिम्मेदारी है Who will be dissecting? You take it. ठीक है आर दुटो नहीं है দুটো কাউন্ট লাগবে দুটো কাউন্ট একটা নিয়ে দেবে এনাকে দিয়ে দে একটা ওনাকে দিয়ে দে খুলে দে ঠিক আছে পেয়েছি এই ওই ওনার মানে ক্যাপ দিয়ে দে কৃষ্ণেন্দু ওই মেয়েদের ক্যাপটা দাও তো ক্যাপ সরি
We are both in second.
Mutually you can exchange, but do not complain later, huh? That's the thing. It's up to all you. এই 7.5 গ্লাস নিয়ে আরে 6.5 রোহন বনে নিছো
কানেক্ট তো স্যার মানে এটা তো ডাইরেক্ট দেখতেই পারবে যদি এটা কিছু করে এটাই কারণ ক্যামেরা তো তাহলে ক্যামেরা দরকার ঠিক আছে
এক্সটার্নাল ভিডিওর দরকার
না ঠিক আছে এইটা কানেক্ট করতে হয় তাহলে
এই বোন দিয়েছো রোহন কোথায় গেল হ্যাঁ এটা সরাবো মানে এটা সাইড রেখে দেবো কোথায় রে এনাকে এইখানে একটা বন্ধে এইখানে একটা বন্ধে আর এই যে ডিসেকশন হয়ে গিয়েছিল তো এটা তুলে রেখে দে সাইডে Just we will be confirming that all dissectors are present at the table. Dr. Akash, Dr. Tanisha, Dr. Sanjana, Dr. Arundhati, Dr. Anshuman, Dr. Indranil, Dr. Shruti, Dr. Manoj, Dr. Kerevin, Dr. Pooja, Dr. Adil, Dr. Shilpa, Dr. Kalpalata, Dr. Tausif, Dr. Polosto, Dr. Syed Mirza, Dr. Hibba, Dr. Rushabh. Okay. The first dissector all have got the bone. Okay. The second they will get when they will be dissecting.
you.